So it's the surgery that we'll be playing. So what I'm talking here, see what happens is, in workshops, if you see faculty operate, people who are experienced, who have many years of experience behind them, who have had their own complications, learned from them, etc. So when there's a lot of polyps, extensive polyps, and you can't see landmarks, then they will take a debrider and they'll debride all the polyps. And then they'll show you this is the middle terminate, this is the unsnit, etc. And they'll continue to debride all the way up to the sphenoid and debride the frontal and everything. And you're left looking, now what do I do? If I take the debrider in my hand, will I be as confident about doing it? Especially imagine if it's a revision surgery where certain landmarks are lost, whether the unsnit process is there or not, whether the middle terminate is there or not. The middle terminate itself may be polypoidal, the unsnit may be itself polypoidal, so you may not recognize them. Sometimes the lamina papyracea is gone, sometimes the skull base is gone, eroded. Then with that debrider in your hand, you're constantly thinking, am I going to damage the orbit or am I going to damage the skull base? So what happens is, it looks very good, the surgery. But to replicate that surgery when you don't have that level of experience becomes difficult. And so what happens is, a lot of people will remove the polyps in the nose, remove as much as is safe in the middle meatus, and then leave behind those polyps. They are not certain whether they can go ahead or not safely. Does that happen? So I'm going to show you a way of doing these surgeries where there are revision cases, where the landmarks are not there, where there are extensive polyps where you can't see anything. All that, how you can do it stepwise, safely, but you can complete the entire surgery. Okay? So this is what I'm going to show you. Now, this is not like regular fist surgery. Okay, it's a different technique. The steps of this surgery are different to a certain degree. They are different. At least the initial part of the surgery is very different from the way you would do fist surgery. Okay, but it's my take on how to make it simple and safe to operate. Okay, so I'll play that for you now.
At the outset, I'd like to thank Professor Rita Kamel and the entire organizing team of Rhino Egypt 2021 for inviting me to share my views. The brief that was given to me for this conference is to present one lecture and one surgical video in the theme of how I do it. My lecture addresses extended applications or the more advanced applications, namely the new approaches for endoscopic excision of angiogram. I thought that I would make this video for primarily the trainee residents as well as those in the first 2 to 3 years of their endoscopic career. I remember as a junior consultant, I used to be overwhelmed and daunted by patients who presented with extensive ethmoidal polyposis. The polyps would go all the way up to the vestibule and no landmarks would be seen. To make things worse, many of these patients were revision cases where the primary surgeon would have probably removed the standard.
You can hear, no, all the way.
Also, thirdly, many of these cases would have erosion of the lamina papyracea on the skull base. This video is to simplify matters. The most basic form of painting is painting by numbers. I'd like you to think of this as operating by numbers. Let me give you a metaphor. If one were to cross a shallow stream, all one would do is wade across it. This is similar to basic breast surgery. You find the unsnit, do an unsinectomy, open the normal maxillary ostium, and then do a removal of the bulla, anterior, posterior ethmoids, and so on and so forth. But imagine that you had to cross a river full of crocodiles. One would obviously need a different approach. And I call this approach stepping stone surgery. Just as one would step on one stone and then use that to step on the second stone across the river, so also we're going to use one landmark and the second landmark, and so on and so forth, making the surgery both effective and safe. For this surgery, I have deliberately used landmarks which the primary surgeon would not have been able to remove in the first surgery. I hope you like this video. This is a case of extensive nasal polyposis. It's a revision case and there are no landmarks seen. We begin first by debriding the polyps along the floor of the nasal cavity at the junction of the floor and the nasal septum.
So you start at the place which is the safest. Which is the safest place? The floor of the nasal cavity has no important structure. If you stay close to the septum, no important structure. So you stay there. You don't even go lateral, because then the inferior turbinate, you may debride the inferior turbinate. So close to the septum and the floor, that's where you start.
So we start with a debrider along the floor and we proceed gradually posteriorly. Since there is no important structure along the floor of the nasal cavity, one can go ahead without being concerned about any damage to any important structure.
So, in workshops you'll see that when there's cases like that, the first thing the faculty will go is start looking for the Ansonet process, right? So you're not looking for the Ansonet process. You're not going anywhere near the Ansonet process, okay? You're just staying in the floor.
As we extend the surgery posteriorly, we are now looking for our first landmark, the roof of the posterior choana.
So posterior choana is the same as choana, okay? I keep using that.
Begin to see the roof of the posterior choana coming into view. This is one landmark which cannot be removed by even the most aggressive surgeon. This is the roof of the posterior choana and it helps give us perspective of the anterior posterior depth.
So what we have done is, we have first established depth, okay? So anytime during the surgery, if you don't know where you are, suppose you're not sure whether you're in the anti-ethmoids or you've gone beyond the ground lamella, either the ground lamella is removed before or it is polyps, and while removing the polyps, you don't know where you've gone, and you don't know whether you're in the anti-ethmoids or you're in the posterior ethmoids or you're in the sphenoid, then you come down again and look at the choana. So if you find that your forceps is deeper than the anterior border of the choana, the roof of the choana, then you're in the sphenoid. If the forceps is more superficial, more anterior to where the choana is, then you know that you're in the posterior ethmoids or the anterior ethmoids. So we are establishing first one parameter, which is depth. So once you have that classical clear idea of depth, so you imagine that if you're doing it like the basic test that you do in the routine way, you have no depth. You have no concept of how deep you are. So what we have done is first created a concept of how to judge depth. Okay. Then what we do, the second landmark is not the middle turbinate.
The inferior turbinate. The attachment of the inferior turbinate is such that it first ascends up to a peak and then comes down inferiorly. And the apex is where the nasolacrimal duct is present. We now delineate the entire inferior turbinate by debriding some more polyps.
So we are not trying to use the middle turbinate as landmark at all. We are using the inferior turbinate. And most surgeons in pest surgery don't remove the inferior turbinate. The middle turbinate, quite a lot of people remove. So we are not looking for the middle. We are looking for the inferior turbinate. Okay.
The third landmark is the maxillary sinus. We use a maxillary suction without the suction attached to it to open the maxillary sinus, not in the normal ostium, but just above the inferior turbinate. This prevents accidental entry into the orbit.
So what we have done is we've used the inferior turbinate as a landmark to find the maxillary sinus. Now, if you are looking for the normal ostium, because there are so many polyps, assuming that the lamina papyracea is eroded, assuming that the partial uncinectomy has been done before, assuming that the uncinate may be polypoidal, there's every chance that you may make a mistake and you may land up in the lamina papyracea or into the orbit. Okay, because even if you can see everything, suppose it's sinusoid, and even if you can see all the landmarks, still there is a concern that you may land up in the orbit. Now, in a complicated, complex case like that, the chance of entering the orbit are higher. So you don't go into the middle meatus at all. You just open the maxi sinus above the inferior turbinate. Now, this is not the normal ostium, but you're opening up the maxi sinus because you're going to use that maxi sinus as a landmark. That opening of the maxi sinus, the roof of the maxi sinus as landmarks to find your way. So that's why we're opening the maxi sinus. We're not trying to drain the maxi sinus to its normal ostium right now. We will do that ultimately, but at the moment we're using that as a landmark more than actually to drain the sinus. Okay, we're not doing final surgery on the maxi sinus. We're still going to operate on the maxi sinus, but this is to create a landmark system. Okay, so that's what we are doing. We are opening it just above the inferior turbinate. Now here,
After the opening of the maxi sinus,
yes.
And just above the inferior turbinates on the superior turbinate, or from you are going from anterior to posterior?
No, not anterior to posterior. Not anterior to posterior. So you see the inferior turbinate, where the inferior turbinate, the upper part of the inferior, just above that. Okay, just above that. Okay. So you're actually below the middle meatus. You're not in the middle meatus at all. You're below the middle meatus, just above the inferior turbinate. Now, does that make sense? Okay.
the fourth landmark is the middle turbinate. We can now see the middle turbinate since most of the polyps along the lower half of the nasal cavity is removed. And we now need to remove the polyps in the middle meatus. We use the maxi sinus opening as a landmark to get the perspective of medial to lateral depth, as the posterior guana gave us the perspective of anterior to posterior depth.
Okay, so what we've done is, why we've opened the maxi sinus is, the plane at which the maxi sinus opening is, if you extrapolate it upwards, the lamina papyracea never comes medial to it, right? It will either be in the same plane, or if because of polyps, if the lamina is pushed, it will be lateral to it. So that plane of the maxi sinus opening is what we are going to use further in the surgery. So whatever we debride in the middle meatus will always be medial to this plane. So you're not trying to remove all the polyps in the middle meatus. You're removing only from anterior to posterior as you're going, you're removing polyps only medial to that plane. That's why that maxi sinus has been opened. So that opening of the maxi sinus gives you a plane, and that is the plane you're using from medial to lateral. Just as you used anterior posterior depth you got from the guana, this medial to lateral, how medial to go and how lateral to go, where will the lamina papyracea be, how lateral will be the lamina, is given by this plane of this maxi sinus. So unlike how we showed you in FEST that you remove all the polyps in the bulla area, then you remove the ground and then you remove all the polyps, you don't do that. You remove only the medial polyps, only the polyps which are along the medial to this plane of the maxi sinus opening.
The plane of
Pardon? Then you would stay as close to the floor. Maybe, a centimeter above the floor. That is where the inferior turbinate would have been. So you open there, okay? The point I'm trying to make is, you don't try to find the normal ostium, you don't go into the middle meatus till you have this opening, okay? When you have this opening, then you will be able to work in the middle meatus.
maxi opening is such that the lamina papyracea cannot lie medial to it. So we use this plane and remove all the polyps medial to the plane of the maxi sinus opening. Thus, we are sure that we are not going to enter the lamina papyracea.
Does that make sense?
The next landmark is the unsnip process. Once we have debrided the polyps in the middle meatus, we can now see the remnant of the unsnip process.
See how it's polypoidal here, okay? If you had gone straight for it, there's a chance that you may miss it completely. You may not realize that's the unsnit. And if you use a debrider there, you will not know when it has gone. Okay.
The point of attachment of this remnant to the lateral nasal wall. And using the uncinate as a guide, we now open the normal ostium of the maxillosinus. We connect this to the accessory ostium that we have made to avoid circus movement. We now debride off the remnant of the uncinate process.
Is that clear so far?
We can do this without worrying about the lamina papyracea because we have a perspective of the lateral to medial distance.
See, when you pull, if it starts stripping the mucosa, you go backwards. Okay, so you don't peel off.
The next landmark is the axilla of the middle turbinate. We first remove a remnant of the uncinate in the uppermost part, and this is the apex of the vertical part of the uncinate process.
So all this we are doing medial to that plane. Okay, everything is
The
medial.
middle turbinate is polypoidal, and there are also polyps in the region of where the axilla of the middle turbinate would be. We skeletonize the middle turbinate by removing the polypoidal mucosa which is present around it. We also remove the polyps in the region where the axilla of the middle turbinate would be. We take care not to remove the polyps right up to the olfactory groove. Remnants of those polyps would be treated by steroid nasal sprays.
That's because you don't want to damage olfaction. Okay.
The previous surgeon has not done too much work in the middle meatus, and the bulla is still intact. We debride the bulla and remove the polypoidal mucosa. We keep always medial to the plane of the maxillosinus opening. We continue to use the maxillosinus opening as a reference point so as to avoid damage to the lamina papyracea.
So even when you are removing the bulla, you routinely in first what you do, you remove the entire bulla so that you can see the lamina papyracea. At the moment we are doing nothing, we are only removing that part of the bulla which is medial to that plane. So you are continuing in the middle meatus, anterior to posterior, till the posterior ethmoids, because keeping that plane in mind. Now the reason we are going all the way up to the posterior ethmoids like that is that the orbit turns like this, right? It's the orbit is not straight line, right? So what happens is in the anterior ethmoids, the lamina papyracea is very difficult to identify in these polypoid cases. Routinely in routine cases you can, but where there's extensive polyps, where there's pushing of the lamina papyracea, it's very difficult to identify that lamina, especially if it's eroded between the polyps and the orbit. So what happens is when you go into the posterior ethmoids and you've gone safely because you've stayed medial to that plane, when you go into the posterior ethmoids, because the lamina is turning, you'll see it more easily. You'll be able to make out that this is the orbital periosteum or this is the lamina papyracea much more easily than you would in the anterior ethmoids. Does that make sense? Anyone who's not understood what I said? Okay.
We continue this as a reference point till such time that we can actually see the lamina papyracea. The next landmark is the floor of the orbit. So when the maxillosinus has been opened widely, we can see the roof of the maxillosinus or what is the floor of the orbit. We now have an idea of where the orbit would lie, superior, inferiorly in the. So this is.
So we had got an anterior posterior depth, right? We got a medial lateral. Now we know that whatever polyps lie in this area will not be anywhere near the orbit because the orbit starts from up here. So now what has happened is you've got a inferior superior, that anything above the roof of the maxillosinus here, you will be careful. But anything below the roof of the maxillosinus over here, you can remove very easily without worrying about the orbit. So that has given you now a superior inferior reference. So now you have references in all three axes, X, Y and Z axis. Okay.
The roof of the maxillosinus the orbit, which will turn upwards to form the lamina papyracea. So, keeping the plane of the lamina papyracea in mind, we can now remove all the cells medial to that plane.
So we are still staying medial, okay? You see there are a lot of polypoidal mucosa still here. You've not removed these cells.
To remove the remaining anti-ethmoid cells as well as go past the ground lamella to remove the posterior ethmoid cells. While we are doing this, we make sure that we stay medial to the plane of the maxillary sinus opening. It is easier to identify the lamina papyracea in the wider posterior ethmoid cells than it is in the anti-ethmoid cells. We now come to main landmark of the lamina papyracea.
Can you see? Once you've removed the polyps in the posterior ethmoid, you can start seeing the lamina much more easily. So we've left behind cells over here, we've left behind mucosa over here, polyps over here. And when we have gone medial to that plane of the maxillary sinus opening, as you open up the posterior ethmoid, as you remove the polyps in the posterior, you will start seeing the lamina papyracea. And then you use that lamina papyracea to come anteriorly and remove the rest of the cells. So you are now following the lamina papyracea from behind in the posterior ethmoids and removing the rest of the cells.
How do you make sure anti-ethmoid artery is not removed?
The anti-ethmoid artery is in the skull. We have not yet reached the skull base. We are not touching the skull base at all. You see, so far we were not touching the lamina at all, right? We were staying medial to it. We are not going to go to the skull base at all. We have not tried to open the skull base at all. We have not tried to remove the polyps over there. We'll come to that in a little while. So that is when you'll have to start worrying about the anti-ethmoid artery. Okay. And tomorrow I'm going to tell you how you can stop worrying about the anti-ethmoid artery completely. Okay, I'll show you how you can stop worrying. You know, when I conduct a course every year, okay, every year I take about 60 hands-on delegates and I conduct a course. And when I'm demonstrating cadaver dissection, before I've done the uncinectomy, everyone is asking where's the anti-ethmoid artery. Okay? So because it's become a sort of paranoia, you know, in everyone's head कि वो anti-ethmoid artery कहाँ है. So we'll talk about it a little more in detail tomorrow. Okay? So do you understand that how the posterior ethmoid, once you remove the polyps in the posterior, you'll start seeing the lamina. It's much easily seen because of that. And then
remove the posteriormost ethmoid cells, we can begin to see the lamina. And now we know exactly where the orbit is. It's a good idea to give warm saline washes between the surgical steps so as to keep the field clear and all the landmarks visible. We can now see the entire lamina papyracea and any polypoidal mucosa, polyps or septae along the lamina papyracea which have been left behind can now be removed with the side of the Blakesley forceps.
Or a through cut forceps, okay? So you use the side because, like I said, if there are dehiscences in the lamina or the erosion, if you use the tip of the side, it can go through. So you use the side, and you can use the side of a Blakesley because when you have such extensive polyps, it's not mandatory to protect all that mucosa. In fact, in extensive allergic fungal rhinosinusitis, don't quote me on this, but I removed mucosa because there's a lot of nidisis of fungus. So when you remove that absolutely unhealthy mucosa, finally the mucosa which heals is healthy mucosa.
Maxillary ridge.
So someone was asking me about the maxillary ridge, just pay attention that
we remove redundant mucosa close to the roof of the maxillary
see
sinus.
now we can do this because we know where the lamina is. We know where the floor of the orbit is. So we know how to remove these cells.
Cell here which needs to be opened. This is, as we said, the roof of the maxillary sinus. That's the lamina papyracea, and the junction of the two is where the maxillary ridge is present.
I think someone who asked, I hope it's here, it's made it clear. Okay.
10th landmark is the posteriormost ethmoid cell. Once most of the posterior ethmoid cells have been opened, we can now now see the posteriormost ethmoid cell. It lies above, that's the maxillary ridge, and the posteriormost ethmoid cell lies above the level of the maxillary ridge. It is pyramidal in shape.
Is at the level of ground level.
So it's a ridge which is formed, first of all, it's a man-made ridge, like the facial ridge. It is a man-made ridge, it's not present. It is a ridge which goes from anterior to posterior. So it's not just at the level of the ground lamella. It is the ground lamella attaches at the level of the maxillary ridge. But what you have is, see, this is the roof of the maxillary sinus or the floor of the orbit. This is the lamina papyracea. So this junction, if you follow it posteriorly like this entire thing is the maxillary. Is that clear? And yes, you're right that the ground lamella will attach at the level of the maxillary ridge. But just this is not the maxillary ridge. Starting from here all the way back is the maxillary ridge. And the posterior ethmoid cell will open above the maxillary ridge. Now let me just go over with you what are the differences. Suppose you open a cell, and this is another common thing which comes up, is that I've opened into a cell, but now I'm not sure whether this is the posteriormost ethmoid cell or it's the sphenoid sinus. Am I in the sphenoid sinus or not? Sometimes we open a posterior ethmoid cell and think we've opened the sphenoid sinus and we leave it behind, and the sphenoid sinus never gets opened. So there are certain things which will tell you difference between a posteriormost ethmoid cell and a sphenoid cell. First of all, the posteriormost ethmoid cell is pyramidal. It's triangular in shape, and it narrows away from you into an point, into an apex. So the posteriormost ethmoid cell narrows away from you and finally reaches a point. That is one thing. Second thing is that the posteriormost ethmoid cell opens above the level of the maxillary ridge. So this is the maxillary ridge. So this is the posteriormost ethmoid cell, and it opens in a coronal plane. So when you open the posteriormost ethmoid cell, you can see the wall of the thing is in the coronal plane. So you open in the coronal plane, and then you see this triangular cell which narrows to an apex and which is above the level of the maxillary ridge. And the third thing, and the final thing, the fourth thing is that the floor of the posterior ethmoid cell is always seen. You can always see the floor of the posterior. As opposed to that, the sphenoid sinus opens below the level of the maxillary ridge, and that opening, the bone which you will remove will be not in a coronal plane but in an axial or oblique plane. Those of you who did dissection today know that ultimately we had to go through an oblique plane or an axial piece of bone to enter the sphenoid sinus. So it will lie below the level of the maxillary ridge 1. Second, it will open in an oblique or axial plane. Third thing is, once you open it, it widens away. It's like entering a big pot. So it's not narrowing away, it widens away from you. So that is the third thing, that it looks like you enter the inside of the pot. And the fourth thing is, no matter how, even if the sphenoid sinus is very small, with a 0-degree endoscope, you will never be able to see the floor of it. So if you are in any cell where you can see the floor of that cell, it can't be the sphenoid sinus. So 4 ways in which you can differentiate between the posteriormost ethmoid cell and the sphenoid sinus. And one of the ways that people don't mention, and which is very, very important, is that the floor is not seen. So the floor of the sphenoid sinus, even a small sphenoid with a 0 degree. With a 0-degree endoscope, if you keep a 0-degree endoscope, you will not be able to see the floor of the sphenoid sinus. Okay? So let's go on.
And has 3 walls: lamina papyracea, the skull base, and the wall common with the sphenoid sinus, and it ends in an apex away from the operating surgeon. This is the maxillary ridge, and we open the sphenoid in an infero-medial direction at the level of the posteriormost ethmoid cell. One should usually open it with a ballpoint, and then one can widen it by opening a Blakesley forceps within the sphenoid sinus and withdrawing it by keeping it open. can now see that the sphenoid sinus lies infero-medial to the posteriormost ethmoid cell. Then now begin to remove the edematous mucosa. And
So you see, that's the posteriormost ethmoid cell. That's infero-medial to that is the sphenoid sinus. That's your maxillary ridge. So posteriormost ethmoid cell above the maxillary ridge, the sphenoid sinus below the maxillary ridge. Okay.
polypoidal partition.
And you can see the floor of the posterior ethmoid cell, but you can't see the floor of the sphenoid. Okay. Now this partition, some people ask me, how much can you remove? You can remove the whole thing.
Here that the posteriormost ethmoid cell lies above the level of the maxillary ridge, while the sphenoid sinus lies at a level below the level of the maxillary ridge.
See how you can see the floor of the posterior and you can't see. You see, you can't see the floor
Can now be seen.
of the sphenoid.
The roof of the sphenoid is an important landmark for skeletonizing the skull.
So you see, so far, now we've cleared the lamina. Okay, we understood how to clear the lamina safely. We've still not done anything about the skull base. Now let's assume that the skull base is eroded. You don't know how to get there. So now we'll see how to skeletonize and remove all the polyps along the skull base. Okay. So the first thing you do is, now that you open the sphenoid, you find the roof of the sphenoid by opening up that sphenoid properly. The roof of the sphenoid is the lowest part of the skull base. So as you come anteriorly, the skull base will move higher and higher. Why do you need to know this? Because sometimes what happens is, because you're so worried that you will reach the skull base, you leave behind polyps. So if you're left behind polyps which are at a lower level than the roof of the sphenoid, you're definitely not near the skull base. It's significantly higher up. So therefore you will use the roof of the sphenoid as landmark. I have to remove everything up to here and above that, to go above that.
Partition between
Okay, this bit you need to see. See how I'm removing this partition. Okay, look at the Blakesley. It sounds that partition. So what you do is you close the Blakesley and you put it behind that partition. See how much that breaks. Like how you feel for cholesterol, right? How much with a circular knife you feel, or with a ballpoint you feel. Similarly with the Blakesley, you go behind the partition, see how deep it goes in, and then remove the partition. So see how it's done.
quite clearly seen here that the posteriormost ethmoid cell lies above the level of the maxillary ridge, while the sphenoid sinus lies at a level below the level of the maxillary ridge. The interior of the sphenoid sinus can now be seen. The roof of the sphenoid is an important landmark for skeletonizing the skull base.
See how I sound it, okay, and then I remove.
Partition between the posteriormost ethmoid cell and the
See again
sphenoid
like that.
sinus
This is how you will do for the entire skull base. From posterior to anterior, this is how you will do it.
Once this is done, the roof of the sphenoid sinus.
So you can see the roof of the sphenoid now
This
here.
is the lowest part of the skull base and is used as a landmark to skeletonize the skull base.
See how you keep feeling like that and removing the partitions.
Using the roof of the sphenoid as a landmark, we can then remove all the cells along the skull base. This is the skull base coming into view. One can see the posterior ethmoid artery. It is important to sound each septum before one removes it, like so.
And see how the forceps is always superior-lateral,
We can now
not
see
superior-medially.
the skeletonized skull base as well as the roof of the sphenoid.
So whenever why are you sounding? If the septa is there, as long as the septa is there, that means you're still in the nose. There can't be a septa going into the brain, right? So if you're using your forceps and going behind that septa, and you can see that the entire forceps goes behind that septa, then you can remove that septa. Because that entire septa is in the nose, it's not in the brain. So therefore that is how you, and as you do it, you'll start seeing the skull base. You'll start seeing, just like you can start seeing the skull base, and at one point when you see it, you will be able to use that to go backwards and forwards and remove all the cells. So
The frontal sinus can either be opened by the intact bulla technique or at the. It is important to sound each septa before one removes it, like so. We can now see the skeletonized skull base.
So that's the roof of the sphenoid, okay? That's the roof of the sphenoid, and that's the skull base. And see, now you removed all the septa
Frontal
between the
sinus
two.
can either be opened by the intact bulla technique or at the end as the last bit of the surgery. A Cone's probe is in.
So in extensive polyps, don't go looking for the frontal sinus first, because you don't know where the skull base is, you don't know where the lamina papyracea is. You may land up in the skull base, because as it is, finding the frontal sinus takes a little effort. So in these extensive polyps, don't look for the frontal sinus. First find the skull base, find the lamina papyracea, remove all the polyps everywhere else. The bleeding will decrease, and then you go looking for the frontal sinus. So don't use the intact bulla technique here.
Inserted into the area from very close to the middle term.
This we'll talk about
and
tomorrow.
is moved in an anterior lateral direction.
We'll talk about this tomorrow.
The direction is important so as to not damage the lateral lamina of the cribriform plate.
So remember, like we spoke, the
Any
frontal
bony
sinus.
partitions which are present in this area, along with any polypoidal mucosa that may be present.
Okay, so this is where you start worrying about the anti-ethmoidal. So all this while we have not had to worry about the anti-ethmoidal. Once you